I'm starting my session. Very good morning to all. Today will be a rapid quick revision for INI-CET. Today I'll be discussing that how to read in this short span and what are the important topics. And more than now, you should do a smart reading rather than reading the whole entire subject. So how can you prepare in the short time is first is you have to prepare the last 3 years paper. If you have to see the pattern of the last 3 years paper, what I've analyzed is the basic topics like the placenta, diabetes, hypertension. These topics are repeated. So these are high yielding topics. So definitely you should know the basic as well as the recent advancement in all these topics. So placenta, which is not asked in many other exams, but INI-CET, they are concentrating on placenta, which is from a basic obstetrics. So please read upon placenta properly. So that can definitely be a question. Placenta, the normal placenta, placental formation, as well as what are the different placental abnormalities that can be asked as image-based questions. And next, I'll be talking about which are the questions or the must-read topics. One is we'll start with the obstetrics. So one is your antepartum hemorrhage, postpartum hemorrhage. Definitely, this is a very, very important. Definitely, either you will get 1 or 2 questions from antepartum or postpartum hemorrhage. So don't forget to read it. Kindly revise the drugs. In postpartum hemorrhage, what should you read? Don't read the whole topic. Don't start from the end. Don't be changing your material. Fix to one particular material, whatever we have started. Don't start reading anything new now. Okay. Whatever you've read, please revise it. When you're talking about PPH, how can you prepare for a particular topic? When you're talking about the PPH, the revision, this is going to be a revision, right? So you have to revise the topics in such a way that what are the drugs used and what is methodologically used. When there is a PPH, what is the first step? What is your second step? What is going to be your third step? Read it in this format. Okay. And it's also important you read what is the dose, what is the maximum number of doses. For example, if talking about the carboprost, which is given a maximum of 8 doses. When you're talking about oxytocin, how much do you give oxytocin? When you say it is prophylactically, how much do you give? When you say therapeutic, what is your dose? Similarly, it is a methogen. The maximum dose, how much you can give is 5 doses. So this is how you have to revise it. Next, coming to another very important topic, definitely, you will definitely have a question. That is a ectopic pregnancy. In all the exams, you can say there's the obstetrics without ectopic is never. So ectopic pregnancy. First of all, you have to identify it's a ectopic pregnancy diagnosis as well as the management. I'll also be explaining further what else to be done. Okay. And the prenatal diagnosis. Yes, this is a very, very upcoming topic. So definitely you can have questions. So previous year's papers also, you could see this prenatal diagnosis questions. It can be asked as image-based questions as well as direct questions. They can frame direct questions. Abortions. So abortions, the methods. Okay. What are the causes for recurrent pregnancy losses? So these are the most important aspect you have to understand. Another one is malpresentation, malpositions, antepartum, intrapartum, fetal surveillance. So that is very important. Antepartum, intrapartum. Yes, intrapartum, you have to know about the CTG. Antepartum, it is obviously the NST. Okay, NST. Another one is your biophysical profile. So these 2 topics is very, very important. And GDM hypertension, as already told, you have to know in and out of GDM and hypertension. In hypertension, very, very important topic, they've concentrated a lot on this magnesium. Okay, so it is important you read everything about magnesium. They framed a lot of sentences directly from the Williams. So the questions are basically from Williams, and the questions options are also formed from Williams. So read it. Already you will be having a material, so it will be easier for you to understand. I will also be explaining today about magnesium. I have chosen topics, so that these topics I've chosen the difficult ones, so that those topics you need not read again. You will finish it in this class itself. Sterilization contraceptive, I have not touched upon it because it's a vast topic. But yes, what you have to read in contraception, remember OCPs, what are the non-contraceptive benefits of combined oral contraceptive pills is a very, very important question. Another one is above the copper T. Another is emergency contraceptive. These three are going to be the star topics. You have to know that in and out. Coming to gynae. See, gynae, definitely malignancies are going to be a very important topic. Carcinoma, cervix, endometrium, their etiology, all these can be asked. But surprisingly, nowadays, they have a lot of questions are framed from carcinoma vulva. Okay. Please read upon carcinoma vulva. All the basic things. They're not going to ask you a high-end questions for carcinoma vulva, but a basic. Once you read the basic, you will be very confident to answer carcinoma vulva questions. So please read. When you're reading vulva, also give a glance on this vaginal, because that is the two things we neglect in gynae. Okay, carcinoma vulva and vaginal carcinoma. Since it's a very rare presentation, we don't give much importance to it. Yes, but please read upon. They are framing questions from carcinoma vulva and the vagina. Mullerian defects, intersex. Intersex, you have to know what is their presentations, and usually they give a presentation. This is a symptom they come with. Okay, so and you have to identify the condition. So that is the framework that kind of questions will be framed. PCOS, OHSS, endometriosis, fibroid, pubertal changes, amenorrhea. These are the other important topics. So these have to be read properly. I think if you read these topics in like give proper revision to these topics, I think your obstetrics and INI-CET, most of the questions you can answer. Okay. Now I'll be explaining certain topics. How do you read it? This is not entirely for revising. You can't revise in 1 hour the whole obstetrics, right? So we will be discussing some of the questions. How are they framing? How you should read for your revision. For example, they've asked a question. This is a previous year question. Which among the following is not a method of MTP in first trimester? What ethacrynid lactate in intraamniotic installation of ethacrynic lactate, manual vacuum aspiration, misoprostol and methotrexate, and DNC. Okay. So here, what is your answer? What is the answer? What is the answer? Are you people sleeping? Come on, answer. A. Yes. Yes, Sahil Jain is right. Only Sahil has answered. I'm not getting answers from others. Okay. See, this is only an example that I have given you. So this is part of your questions from abortion. Okay. What are the first trimester methods? What are the second trimester methods of MTP? They can frame a question like, what are the drugs that is used in first trimester NTP? So what are the drugs? It is misoprostol, misoprostol 1, mifeproston 2, methotrexate 3. Remember, tamoxifen is also used for the first trimester abortion. So that's how they can frame questions. Next is very important question from the first trimester abortion is manual vacuum aspiration. So manual vacuum aspiration syringe is done only up to 12 weeks. Remember this. This is also a direct question. Up to 12 weeks. What else you have to know about it? You have a syringe fitted to a Carmen's cannula. This is called Carmen's cannula. Okay. Here you're using a vacuum you're creating. So the syringe capacity is 60 ml. where you use a pressure. What is the vacuum pressure that is created inside this? Remember 60, just add one more 660 mmHg, and it is fitted with a Carman's cannula, and it's a handheld syringe. What else they can ask you question is a scenario can be asked. Remember, there is an accidental perforation of this Carman's cannula into the uterus. It's a pregnant uterus. It's highly vascular. While doing with the suction, what happens? Accidentally, if somebody perforates, what is your next management? What is your answer? What will you do? Will you leave the patient? Matlab, you think wait and watch, or will you take the patient for a laparotomy, or you take the patient for laparoscopy and repair it? What is your answer? Of the three, what can be the answer? Wait and watch, laparoscopic repair, laparotomy. Laparoscopy, okay. See, here is where, see, definitely yes. Everybody are answering, yes, definitely this requires repair. You have to decide what mode, whether you do a laparoscopic or a laparotomy. That will depend on the patient's condition. The question will definitely mention you whether the patient is hemodynamically stable or unstable. If the patient is hemodynamically stable, you'll go for a laparoscopy. If a patient is unstable, definitely you have to do a laparotomy. What about if the perforation with a dilator? What happens if you accidentally perforate with a dilator? Hegar's dilator, you have perforated the uterus. So what will you do? Do you repair it? What is your answer? Wait and watch, definitely. Yes, Sahil is right again. See, when you talk about why you wait and watch in case of a Hegar's dilator and not in a Carman's cannula, in Carman's cannula, there is a vacuum that is created. So what happens when you perforate the uterus and go, the suction will pull all the abdominal structures near it. So it is important that you repair it. Whereas in Hegar's, there is no suction effect in Hegar's, so definitely you can wait and watch. But if the patient is unstable, definitely you have to repair it. Okay, this is another way of reading. Next important thing is about the second trimester. What are the drugs used in second trimester? Okay, misoprostol, which is used in first, is also used in second. Remember, mifepristone is not used in second trimester abortion. That is very, very important thing you have to remember. So your revision should be in this manner. You understand what comes under the first, what comes under the second, and accordingly you can answer it. Remember, carboprost is also used as a drug in the second trimester. Though when you come to the second trimester, what is the most commonly used comparing to the medical or the surgical? It is the surgical method. That is surgical in the sense dilatation, evacuation, using a ovum forceps until 15 weeks, or you can use oxytocin. Last, when all this fails, or the intra-amniotic or extra-amniotic installation of this ethacridin lactate or prostaglandins. And if all the methods fail, the last option will be your hysterotomy. Okay, so this should be your revision. This is how you revise. Only then you will be able to answer your exam. So please revise in this way. See, I don't have a lot of material here. I just have this table. Okay, with this table, you should be able to revise the whole of the drugs that is used in abortion. Okay, next. Yes, of course, I was talking about vulval cancer. Vulval cancer is an uncommon tumor. Okay, that's why we are not giving any importance to it. But the exams have a lot of questions from vulval cancer. Please read it properly. What is this was a previous year question, most common age group. See, the question framed is very simple, but you should know the basics of vulval cancer. It's a simple question. It's 3 to 5% of the gynecological malignancy. Remember, the postmenopausal is the most common age group between 55 to 60 years. Postmenopausal, when I say, it's a large gap. But remember, the what is average they say is 55 to 60 years. The most common variety is a squamous cell carcinoma, and the most common symptom is not bleeding, it is pruritus. Most common site is labia majora, followed by minora. The most common route of spread is by the lymphatics, and the most important prognostic factor is the lymph node status. What are the risk factors for vulval cancer? This is also a previous year question. So you should know all the risk factors. At least these are the risk factors. One is VIN, that is vulvar intraepithelial neoplasia, HPV. 40% of the carcinoma vulva HPV positive, 80% of these are HPV 16, HIV, smoking, lichen sclerosis, vulvar dystrophy, hypertrophic, Paget's disease. So please remember these are the risk factors for the vulval cancer. So please, once you read upon the basic, you will have the confidence to answer vulval cancer. You can do rule out options. Rule out options, at least by that also you can answer a vulval cancer question. Yes. As I was telling, they have framed, last year paper had a lot of questions from magnesium. Each line was from Williams. So I have again consolidated everything from the Williams. I made it into a table. This also you have to revise it before going to exam. Please look upon the each sentence that I say. Same thing has been asked as options. See, magnesium is not given to treat hypertension. See, when do you give magnesium in pregnancy? In case of preeclampsia, severe preeclampsia, or they are imminent for the eclampsia. So, magnesium sulfate is not given to treat hypertension. Magnesium sulfate is not an anti-epileptic. It is anticonvulsant, neuroprotective, it is tocolytic, and it decreases the risk of cerebral palsy in preterm babies. Okay, these sentences are all questions. Okay. Pharmacokinetics can be given or IV-IM, that everybody knows. You have many regimes, IV regimes, IM regimes. Onset of action, immediate. Duration of action is 30 minutes. That's why you start with your maintenance dose. Excreted totally by the kidneys. When I say excreted totally by the kidneys, is it important that if the patient have already a poor renal function, regardless of the renal function, you will still give a magnesium sulfate to the patient, because most of them with most of the convulsions will stop with the loading dose. If the magnesium sulfate toxicity is reflected by decrease in the GFR, as increase in the serum creatinine level indicates it's a magnesium sulfate toxicity. See, magnesium sulfate toxicity is going to be a separate topic now. But remember, these are all questions. Most convulsions will stop with your loading dose. Magnesium sulfate is completely excreted by the kidneys, but still loading dose of magnesium sulfate can be administered regardless of the renal function. Another 15%, okay? Women with the subsequent convulsion, additional of 2 grams of 20% of the magnesium sulfate should be given IV. So these are the sentences that it is written already, must know sentences. These are direct options they are giving you. Okay. What are the regimens? Lot of regimens commonly used. Everybody knows a Pritchard regimen, but this is in foreign countries. Indian women's are of low, the body surface is less compared to that of a foreign women. So they prefer with the DACA regimens. But what commonly used all over is a Pritchard regimen. Other regimens names you should know, which are the IM, IV regimens. And mechanism of action of magnesium sulfate, which blocks one, it blocks the NMDA receptor, all the excitatory things it will reduce. So thereby acting as an anticonvulsant, blocks the calcium channel, thereby decreasing the calcium level. When the calcium level decreases, there is vasodilatation, cerebral edema decreases, seizure activity decreases. What are the other mechanism of action? Blocks the release of glutamate. Sorry for the color. Another one is, I already told, that is NMDA receptors, block the calcium entry and the increased, basically decrease the calcium level. So increase calcium uptake by the mitochondria. So this is how you again revise it. So this table, you will again read it properly. Okay. Next, coming to our toxicity. When I talk about toxicity, what to be monitored when you're giving magnesium sulfate, and how is the toxicity reflected, and what is your management? Okay. The simple table that is explains everything. What is the therapeutic dose? It's 4 to 7 milli equivalents per liter. When you're talking about milligram per deciliter, it's 4.8 to 8.4. When you're talking about millimoles per liter, please read upon the option what is given, whether it's given in milli equivalent per liter, milligram per liter, or millimole per liter. That's why all the three values have been forms of the values I have written here. So read what is asked. Don't jump. As soon as you say therapeutic dose, don't jump to your answer. See what is, whether they've asked in milligrams or millimoles or milliequivalents. Most times they will ask you in milliequivalents per liter. How do you monitor? First one is your deep tendon reflex. That's what you see. Next is your urine output, at least 30 ml per hour or 100 ml in 4 hours. Respiratory rate should be more than or equal to 16, SpO2 of more than 96. Okay. Another one is cardiac. Cardiac, we are not monitoring anything as such. When the patient presents with toxicity, they might present with even cardiac arrest. So, how is your toxicity? 10 milli equivalents is the first sign. That is, deep tendon reflexes is the first one to disappear at the value of 10 milli equivalents. Another one is if the magnesium sulfate is also reflected, toxicity is also reflected by increase in the serum creatinine levels. Respiratory depression, it's more than 12. Respiratory arrest is more than 15. Okay. And for the cardiac arrest, it is more than or equal to 30 milli equivalents can cause cardiac arrest. Talking about the management, if the disappearance of the deep tendon reflexes, withheld a dose and restart once it returns. Okay. Talking about the creatinine levels, you can see a rising creatinine levels. Next IM dose decrease by 2.5 grams. If there is respiratory depression, there is an antidote. See, this is again a question. Antidote. There are two antidotes can be used, where one is the calcium gluconate, 10% calcium gluconate, or the calcium chloride 1 gram IV. If there is a respiratory arrest, you definitely have to intubate. Cardiac arrest, intubate and resuscitate. Another very important question is, till when you have to continue the magnesium sulfate? Seizure occur before delivery, continue 24 hours after delivery. If seizures occurred after delivery, 24 hours after the last seizures. So this also have to be remembered. So please revise this table, very, very important table. So for magnesium, this is more than enough to answer your questions. Okay. Of course, next question is biophysical profile. Biophysical profile is a star question. They will definitely ask, they might ask you what are the components. It's a gross body movements, okay? Gross body movements, fetal breathing, fetal tone, amniotic fluid, and NST. Okay? The mnemonic for this is Batman. Its mnemonic is Batman, okay? Read, just correlate with this. What is modified biophysical profile? Definitely they'll ask. It is with NST and amniotic fluid volume. You do a NST and AFI. This is big quicker. This will take up to 20 to 40 minutes to complete. This is a quicker form. You do a NST for 20 minutes. AFI will not even take 5 minutes. You can finish this in less than 20 minutes. Okay. And this is a screening test performed for only 10 minutes. But remember, NST should always be done for 20 minutes. comparable with the BPP. So most commonly in the most of the institutes where you have a lot of patients, they go with the modified biophysical profile. When at most time they'll be asking what are the components of the biophysical profile. If they have to be more mean and they have to ask a question, what is the highest score, what is the lowest score? Highest score is 10 and the lowest score is 0 or 2. Okay. Yes. This question has been like creating a lot of confusions. Remember, what is the WHO says, what is the minimum number of antenatal visits? It's going to be 8. This is what the table I got from WHO. There's something called 2016 WHO antenatal care model, where they have changed 2-3 things. One is they have changed this the word of visits to contact. Okay. So, and the minimum number of contacts, again, it's not visit. The minimum number of contact is 8. Okay. Talking about the Indian scenario, it is going to be 4. No confusion. If they're talking about the WHO, please write it as 8. If it's number of visit in the Indian scenario, it is 4. What are the antenatal screening or the first antenatal visit is also called booking visit. What are the investigations to be done? This is also a previous question, very simple question. Just we'll revise it. Hemoglobin, you definitely do the blood group and typing, all the viral markers, especially HIV, HBsAg, VDRL. In some hospitals, they do this HCV also, but not routinely done. Urine routine and microscopy and culture is a very must investigation to be done at your first visit according to ACOG 2017. Okay. So definitely urine routine and microscopy should be advised at the first booking visit. Similarly, screening for GDM, either you do a DIPSI or you do a 75-gram GTT, or at least you have to do a fasting postprandial. When do you do fasting postprandial value? When the patient complains of excessive vomiting, instead of loading her again with a glucose, that will again induce vomiting, you can do a fasting postprandial. But once she reaches the second trimester where her vomiting has been controlled, you will do a 75-gram DTT or a DIPSI. But remember, what an Indian scenario always says, at the first visit, you do the screening for GDM with your 75-gram DTT or with at least with a DIPSI. Another very important thing that the cervical eversion occurs during pregnancy. It's a very ideal or apt time to take a pap smear. So pap smear is also done at the first visit, especially if they come in the first trimester. Any doubts till now? Do you have any doubts? Can I continue? Yes. So next question that recently they are asking both from NEET as well as from this INI-CET is the Anemia Mukt Bharat. Okay. This is also called Intensified Iron Plus Initiative. This has been launched by UNICEF in 2018 to reduce the prevalence of anemia all over India, not only for pregnant women, it is for all. So you can see her chart here. These are the beneficiaries. They start from children, adolescent boys also is included, adolescent girls, women of reproductive age, pregnant women and lactating women. It's not only for the pregnant women, it's for many. There are 6 beneficiaries. Okay. That's why it is called 6 into 6 into 6 means strategy, 6 beneficiaries, 6 interventions, 6 institutional mechanisms. So that is what is about the Anemia Mukt Bharat. What you have to know from the obstetric side is, one is prophylactic iron and folic acid. what is, I have written detail here. See, what they're telling is you have to give iron and folic acid. Iron and folic acid both to be given at 180 days in the antepartum period, 180 days as well as in the postpartum period. Iron contains 60 milligram of elemental iron and folic acid to be given as 500 microgram. All should be sugar coated and it is red color. Okay. Next is about the deworming. Deworming tablets of 400 milligram of albendazole after the first trimester, preferably during the second trimester. Very important, another very important thing from obstetric point of view is compliance. Check for the compliance. If the patient is compliant with whatever iron or calcium, that is one important thing. Appropriate infant and young child feeding. So teaching the mothers the correct way of feeding, prompting the practice of delayed cord clamping. When you say delayed, after the stoppage of pulsation, or to be very precise, at least 3 minutes. Okay. And initiation of breastfeeding within 1 hour of birth. So these are the very, very important thing they have mentioned in Anemia Mukt Bharat. And this is a treatment that they have mentioned. So what you have to know is just read upon this table. I'm not going to go in detail. Remember, for the treatment, they have advised iron sucrose as well as FCM, pericarboxy maltose. So that is very important aspect you have to remember. Okay. These two things are under the Anemia Mukt Bharat. Another very important thing is Suman. Okay. This is also something new. Remember Suman guidelines. It's a Surakshit Mantritva Ashwasan. It's an initiative for the zero preventable maternal and newborn deaths. Under this, you have 6 services that have been provided under the Suman. One is ambulance service, minimum of 4 antenatal checkups, normal delivery or cesarean section. That is all done. All the services are done. All are free of cost. Medicine, lab test for the mother from the conception to 6 months after delivery and baby up to 1 year. Proper care with respect and dignity. Okay. That is a very important aspect which is emphasized in each and every guidelines. Proper care, respect and dignity during the labor. Grievance redressal mechanism. So if they have any other compliant problem with the institute or to the delivery center, they could call to this toll-free center and they can register the complaint. So this is about the Surakshit Mantritva Ashwasan. So I thought this you should be aware. This is also a recent one. Yes. Talking about ectopic pregnancy. Yes. Ectopic pregnancy, I have just talking about the approach. I'm not going in detail. Okay. Pregnancy of unknown location means we will see what does it. Okay. Amenorrhea. If the patient presents with amenorrhea, her UPT is strongly positive. She comes with vaginal bleeding and her vitals are stable. Okay. Now you will not decide the patient is ectopic. Okay. If the vitals are unstable, you will definitely give her a diagnosis of ectopic pregnancy. First diagnosis will be ectopic and take her for laparotomy. It can be anything, but whenever a patient with a positive UPT positive with who had amenorrhea of, it will be mostly it will be 8 to 10 weeks, UPT positive with a vaginal bleeding and she's unstable, definitely you will first diagnosis will be your ectopic pregnancy. Then you do a if her vitals are stable, definitely take her to do a ultrasound. You can see a gestational sac in the uterus, no doubt. It is an intrauterine pregnancy, not to worry, ask her to continue, give her folic acid. Okay. If the uterus is empty, then problem arises. Adnexa should be checked. Next, you're checking your adnexa. Adnexa, you can see a gestational sac plus cardiac activity, your direct diagnosis of ectopic pregnancy. But the problem arises, still you're not seeing any gestational sac nor any cardiac activity in the adnexa. Then you have to think of 3 options. Either it is an abortion or it's an ectopic pregnancy or an early intrauterine pregnancy. Okay, this is called the pregnancy of unknown location. That is, you don't know where is the exact location. So what is your next step of action? Next will be your beta HCG. So critical titer, remember for TVS, it is 3,500. Previously, it was 1,500 international units. This is changed into 3,500 international units. And for the trans-abdominal, it is 5,000 to 6,000. Critical titer is where the beta HCG, where you should be able to visualize the gestational sac. Okay. If it is the beta HCG you have done and it is less than 3,500, you will repeat after 48 hours. If it decreases, that means it's an early pregnancy loss. If it's doubling, it is intrauterine pregnancy. It is plateauing, it is labeled as ectopic pregnancy. This is another way, but you have a more than 3,500 beta HCG and empty uterus, do a DNC, chorionic villi, if it's present, it is intrauterine pregnancy. Chorionic villi is absent, it's an ectopic pregnancy. So this is how you remember for the pregnancy of unknown location. Yes, of course, these can be your direct, straightforward questions. That is, ectopic pregnancies at the other sides. If it's an abdominal pregnancy, it's called the Studi-Fort's criteria. See, it's very simple. When you say the criteria is not very complicated, it's very common sense. See, the pregnancy is in the abdomen, okay? It's in the abdomen, it's not in the uterus tube. So bilateral tubes, the ovaries will be normal. Absence of, there should not be any fistula. Pregnancy must be related to the peritoneal surface. Simple, okay? It's in the abdomen. Talking about ovarian. Ovarians is Piggelberg's criteria. So when I talk about the ovarian pregnancy, so the pregnancy is going and occupying the place of the ovary. So the tube on the affected side is normal. Tubes are normal. Gestational sac will sit in the place of ovary. Gestational sac will be connected to the uterus. So when I say the gestational sac is going to occupy the ovary position, so it will be, the ovary is connected to the uterus by the ovarian ligament, right? So the gestational sac will be connected to the uterus by the ovarian ligament. Ovarian tissue must be found in the gestational sac. Talking about cervical pregnancy, it's called the Rubin's criteria or Palmel McEllen criteria. Remember these, both the names. Okay. Uterus will be, so it will give a hourglass appearance. So this is the uterus, this is the cervix. So it gives a hourglass. The uterus will be smaller compared to that of the distended cervix. The internal os will not be dilated, whereas external os will be dilated. It will be open earlier than that in a spontaneous abortion. Curettage, you do a curettage of this endometrial cavity, definitely you're not going to get any placental tissue because the pregnancy is in the cervix. Going and curating in the uterus, you're not going to get any of the placental tissue. Heterotopic pregnancy is what you have one in the uterus, simultaneously another is a ectopic pregnancy. So ectopic coexists with the intrauterine pregnancy. It's called the heterotopic pregnancy, and it is very common in a IVF compared to that of a spontaneous. Okay. Yes. I was talking about placenta. See, it's a very basic question, okay? But they will definitely ask you questions from placenta. So either as a image-based questions or direct questions. What can they ask? So, it's a discoid, deciduate, hemocoroidal. Weight of the placenta at term is going to be 500 grams. Ratio of weight of placenta to the fetus is 1:6 at term. Baby is 6 times that of the placenta. Gestation at which you have the weight of placenta that equals to that of the weight of the fetus is 17 weeks. What is the diameter of the placenta? 15 to 20 centimeter. Okay, what is the thickness? In the center, it is 3 centimeter. All these are asked as a direct questions. Okay, these were the options. See, this is the previous year question. Weight of which is not seen in normal placenta. Weight is true. Diameter 25 15 to 20, 22 they have given, it's okay. Placenta with 2 vessels. Is placenta having 2 vessels? Umbilical cord have 3 vessels, right? How to remember this? Single umbilical artery is the anomaly. So what is normal then? 2 umbilical artery is a normal one. So 2 umbilical artery, 1 vein is your normal. Okay. When you're talking about the maternal and the fetal surfaces, maternal is dull red. Lobes, how many do you have? 10 to 38 masses. Cotyledon is also called the lobules. These are the functional unit of the placenta, and they are mainly from the main villus or the stem villus. These are formed by the decidua basalis. This can be a question. And from where is the separation? Decidua spongiosum. The line of separation or the plane of separation is at the decidua spongiosum. And Nitabush layer and Hoffbach cells are nothing but the fetal macrophages that are also present on the maternal side. When we're talking about the fetal side, which is shiny gray in color, which is covered with the amnion, and it also has an umbilical cord, and it is formed by the chorion frondosum. Okay, what are the hormones? See, this is a table from the Williams. HCG, human placental lactogen, adrenocorticotrophin, CRH, gonadotrophin releasing hormone. These are from the these are primary non-placental site of expression, but it also shares structural or functional similarity. So which are the drugs, which are the hormones that share, see, HCG, similarity with the LH, FSH, and TSH? That can be a question. And very important, another important thing should be HCG. You should know everything about HCG. It's a basic hormone. What is the doubling time? When does it disappear in case of an molar pregnancy? So all these are the very direct questions. So you should not make mistakes in that kind of direct questions. Okay. So these are the hormones. When I'm talking about the intersex, there was a direct question from Turner syndrome. So Turner syndrome, just read this table. That's more than enough for you to answer any of your question. The Turner syndrome is a hypergonadotrophic hypogonadism. Okay. So what is mosaic is 45X0. There are many mosaics, but remember the most common is 45X0. The most common presentation is primary amenorrhea, but remember the external genitalia develops and it is normal. Testosterone is absent. The fallopian tubes, uterus, vagina, cervix, everything develops. Remember, all are infantile. So the star to remember is bilateral streak ovaries, optimum estrogen levels, secondary sexual characters, either it's absent or less developed, and decreased height, short stature. Another very important thing you can see here is webbing of neck, short stature, low posterior hairline, broad chest, and widely spaced nipples, cubitus valgus, okay, coarctation of aorta, streak ovaries, infertility, amenorrhea, peripheral, that things are not very important. What I marked are all are the characteristic features. Neonatal period, what we have to know, which is the most common cardiac problem that you encounter in case of a Turner syndrome, is the coarctation of aorta. The same thing when you're talking about in the adult life, very, very important thing, they have a normal IQ. So the male counterpart of the Turner syndrome is called the Noonan syndrome. It is an autosomal presenting with same like a streak ovaries. How is it different from that of a Turner syndrome? Remember the pulmonary valve stenosis that you can see, whereas in Turner syndrome, you have coarctation of aorta. Mental retardation is present in case of Noonan syndrome, whereas in Turner syndrome, there is a normal IQ. So this difference you have to remember, and this can be asked as a question. Yes. Of course, you're going to the next topic is the Prenatal diagnosis, as I told, this is a very, very upcoming topic. So prenatal diagnosis. So there's a simple way I can explain to you. See, this is a uterus. Think this as a uterus. Okay. The fluid around the baby is taken out. That is called the amniocentesis. Okay. If you're taking a tissue, you're taking a placental bits, that is called chorionic villus sampling. As the name say, you're taking the chorionic villus. So it's called chorionic villus sampling. When the same thing, you take a blood from the cord, it's called the cordocentesis. It's also called